Good afternoon, everyone. Our next topic is the physical examination of the thorax and lungs, also known as the chest physical examination. Okay, so for this lesson, we're going to briefly review the anatomy and physiology. After that, we're going to discuss the common conditions that you're going to encounter during your history taking. And lastly, we're going to discuss briefly how to do the full physical examination of the chest. But first, why do we need to review the anatomy and physiology? It's because in order to locate our findings, in order to describe it properly, we need to be able to know the anatomy. Okay, so this is the chest wall anatomy. This is the anterior view, meaning you're looking at the patient from their front. Okay, so this bone here, of course, is the sternum. It's composed of the manubrium as well as the body of the sternum. And in between them is the sternal angle, also known as the angle of Louis. Okay. And we have 12 ribs. Ribs 1 to 7 articulate with the sternum. Okay? While ribs 8, 9, and 10 articulate with the cartilage, costal cartilage, just above them. And lastly, ribs 11 and 12 are the so-called floating ribs because they do not articulate anteriorly. So the 11th rib, you could feel it laterally, while the 12th rib, you could feel it posteriorly. Okay? So when you're describing chest findings, you need to describe them in two dimensions, along the vertical axis and around the circumference of the chest. For the vertical axis, you need to know the numbering of the ribs as well as the intercostal spaces. While for the circumference of the chest, use the vertical lines for location. So again, when we're describing findings, we need to describe it in terms of the vertical axis as well as in terms of the circumference. Okay? So, how do we describe in terms of the vertical axis? You have two approaches, anterior approach and the posterior approach. Anterior approach, you're in front of the patient. Posterior approach, you're behind the patient. So in the anterior approach, to do it, first you need to feel the suprasternal notch. It's this notch here. It's very palpable, right? Then you move around 5 centimeters down to the sternal angle, also known as the angle of Louis. The second rib is adjacent to that angle. Okay? Also, when you're describing interspaces, meaning the spaces in between the ribs, you name it after the rib above it. So for example, the second interspace is located below the second rib. Okay? So from there, you walk down the interspaces. So you could clearly count up to the 7th rib because all of these ribs articulate to the sternum. However, for ribs 8, 9, and 10, it may be more difficult because they articulate to the cartilage above them. And lastly, 11 and 12, you do not feel them anteriorly. You feel them, rib 11, you feel them laterally, and rib 12, you feel it posteriorly. Okay? So the alternative to that is the posterior approach. So you don't have the suprasternal notch as a landmark there, right? Because it's located in front. So what you do there is, you use the 12th rib as the starting point, meaning the lowermost rib, for counting ribs and intercostal spaces posteriorly. If in the anterior approach, you walk down, in the posterior approach, you walk up the interspaces to count which rib is involved. Oh, by the way, can you feel the difference between a cartilage and a bone? You cannot. So you cannot differentiate it based on the feel alone. And okay, so there are important landmarks that we have to remember because these have clinical relevance. So for example, the second intercostal space is the needle insertion point for tension pneumothorax. So for example, a patient involved in an accident, and then there's a flailing chest. So there's a ball valve effect causing the air to be trapped inside. In order to relieve that pressure, for the patient to be able to breathe, you need to insert a needle at the second intercostal space. Remember, it's below the rib that articulates at the sternal angle of Louis. The fourth intercostal space, on the other hand, is used for a chest tube. So for example, if there's a hemothorax and you need to drain it so the patient will be able to breathe, you need to insert it at the fourth intercostal space. Okay? T7 and T8 interspaces are the landmark for thoracentesis. For example, if the patient has fluid in their lungs, in their pleura, and you need to drain it, you need to perform thoracentesis at T7 and T8 interspaces. And lastly, the inferior tip of the scapula is usually at the level of the 7th rib or interspace. Now we know how to describe findings in the vertical axis. How do we next describe findings circumferentially? For that, we have three sets of lines. anterior lines, axillary lines, and posterior lines. So first, starting with the anterior lines, the middlemost line is the mid-sternal line. It's the line that passes through the center of your sternum. It's midline. Next, the most lateral lines in the anterior view are the anterior axillary lines. Okay? And lastly, the midclavicular lines. So how do you identify the midclavicular lines? It's located at the middle of your clavicles. So in order to identify the midclavicular line, you need to identify the endpoints of your clavicle. You need to feel for it around here and around here, right? Then the center is going to be where the midclavicular line passes through. Next, we have the axillary lines. The axillary lines are defined by the folds that demarcate the axilla, yung kilikili, no? Yung muscle masses doon. Okay? So the anterior axillary line passes through the anterior muscle masses, while the posterior axillary line is demarcated by the posterior muscle masses. Lastly, in the middle of them is the mid-axillary line, which is aligned with the apex of your axilla, meaning yung pinakamalalim doon, no? Na point ng kilikili. Right. Lastly, we have posterior lines. For that, we have two sets. The vertebral line, which is simply the midline, which passes through the spinous processes of your vertebrae. Okay? And the other one is the scapular line. The scapular lines pass through the inferior angle of your scapula. Next, let's review the anatomy of the lungs. So what are the borders of your lungs? So the uppermost part, or the apex, rises above the inner third of your clavicles. Specifically, around 2 to 4 centimeters is this portion here. That's the apex of the lungs. So for example, someone with tuberculosis, most likely they're going to have some lesions in the apex of their lungs. Okay. Next, the anterior lower border crosses the 6th rib at the midclavicular line, while the posterior lower border lies at about the T10 spinous process. So it's slightly lower at the back. Okay. Also, the lungs are divided into lobes. The right lung is divided into upper, middle, and lower lobes, while the left lung is only divided into the upper and lower lobes. Take note, there's no middle lobe for the left lung. Also, the upper and lower lobes are separated by the oblique or major fissure. How about for the right lung? Diba merong upper and middle lobe? So those are separated by the horizontal or minor fissure. How about the tracheobronchial tree? Trachea, remember, is the windpipe. Okay? So, when you inhale, of course, food goes into the esophagus, but air should go into the trachea. Okay? The epiglottis should be monitoring this. However, in some cases, you could aspirate, meaning it goes down the wrong pipe. For example, pediatric patients. Sometimes they could aspirate on small objects. So question, if you have a pediatric patient who aspirated on a peanut, which is going to be the more likely location of the peanut? Is it in the right main bronchus or in the left main bronchus? The answer is it's going to be located in the right main bronchus. Why? Because the right main bronchus is wider, shorter, and more vertical than the left. Okay? That's why aspiration pneumonia is more common in the right middle as well as the right lower lobe. It's because of the anatomy of the bronchi. Okay? Okay, now let's clarify the pleura. So the lungs are covered by visceral pleura. However, the chest wall is covered by the parietal pleura. Okay? So the visceral pleura is the part that covers the lungs, while the parietal pleura lines the pleural cavity. And take note that they are continuous with each other, and there is also a potential space between them. So there are some conditions in which something accumulates in the pleural space. So it no longer becomes a potential space. It becomes a fluid-filled space. So what could fill that? It could be inflammation, inflammatory fluid, or it could be blood. Okay? And that condition is called a pleural effusion. Okay. We're not going to discuss the physiology in depth. We're just going to tackle inspiration and expiration. Okay? Inspiration is a largely active process, while expiration is a largely passive process. Of course, unless you breathe out forcefully. So during inhalation or inspiration, the principal muscle involved is your diaphragm, of course. So when it contracts, it descends, expanding the thoracic cavity, making the pressure inside more negative than the atmospheric pressure. Sometimes, the scalenes and the parasternal intercostal muscles could also assist. In contrast, during expiration, what drives the collapse of the lungs is the chest wall and the lungs recoil. No? So it's a natural recoil. Okay. So if you forcefully expire or if you forcefully exhale, the abdominal muscles could sometimes assist. Okay. During exercise and in certain diseases, extra work is required to breathe, and accessory muscles like the sternocleidomastoids become recruited. So when the sternocleidomastoids are involved during the breathing, it means that there is increased work of breathing. So it's a finding that you could note in your chart. Okay. Aside from that, you could also note that the patient has labored breathing. We're done now with the first part of the lecture, which is the review of anatomy and physiology. Now let's go to the common symptoms that you're going to encounter during your health history. So we're going to tackle this: chest pain, shortness of breath, also known as dyspnea, wheezing, cough, blood-streaked sputum or hemoptysis, as well as daytime sleepiness or snoring. Let's start first with chest pain. Take note that when a patient complains of chest pain, it's not necessarily cardiac in origin. So your differentials are going to be either cardiac, pulmonary, gastrointestinal, for example in the case of reflux or GERD, musculoskeletal, as well as psychogenic causes. Okay? So always consider a dual investigation of both thoracic and cardiac causes because these are the most serious ones. Thoracic, meaning pulmonary, as well as cardiac. Okay, so there are some clues. There's a clue called a Levin's sign, which is a clenched fist, suggestive of intense cardiac pain, described as heaviness. So it suggests angina, which is cardiac in origin. In contrast, if the patient is able to point their finger on a certain location of the pain, meaning they could pinpoint the source of the pain, then it's most likely musculoskeletal pain. This one is more benign, meaning you don't need emergency treatment, and this condition is called costochondritis. Most of the cases you're going to encounter in the emergency room are going to be costochondritis actually. But of course, you don't want to miss on any cases of heart attack, right? Okay, so when we say that it's from the heart, the common description is heaviness. In Filipino, parang dinadaganan, parang iniipit, parang ini-squeeze or iniipit. But there are many different sources. It's not just all coming from the myocardium. It will also come from the pericardium as well as from the aorta. So the classic heaviness is seen if it's myocardium. So it could be angina pectoris, which just requires maintenance medication. But what you want to rule out is an emergency, which is a myocardial infarction or a heart attack. Okay. In contrast, if the pericardium is involved, it's called pericarditis. No? So the quality of the pain is different. Aortic dissection is a more sudden onset pain. Okay? And sometimes it retreats to the back. Okay. So those are the cardiac causes. How about for the pulmonary causes of chest pain? For that, we have parietal pleura. So the description is different from cardiac pain. Cardiac pain is heaviness, but parietal pleura, the pain is more sharp in nature, sometimes described as stabbing, and the causes are multiple. It could be pleurisy, pneumonia, or pulmonary embolus. So pulmonary embolus, as if you would understand, it's a blood clot. In other words, it's also cardiac in origin, but the affected system is pulmonary. Okay, second to the last, we have chest wall, also known as musculoskeletal pain. These are the most benign. So costochondritis, if that's the condition of your patient, then you just need reassurance as well as pain medications. Okay? Lastly, gastrointestinal pain. So reflux could be localized in the chest, but of course we know that the location of the stomach is epigastric, but it could radiate, of course, to the chest. It could be felt there. So what are the common causes of esophageal pain? Could be GERD. Okay, so these are the causes or the differentials that we're going to consider when someone complains of chest pain. Is it cardiac in origin, pulmonary, chest wall or MSK, or gastrointestinal? Next, let's clarify the terms dyspnea, wheezing, and cough. So dyspnea is painless, but it is an uncomfortable awareness of breathing, inappropriate to the level of exertion. So, in Filipino, hingal. No? Naglakad lang ng hagdan, umakyat lang ng hagdan, ilang baitang, hingal na. Okay? So, it's a key symptom of various cardiac as well as pulmonary diseases. So, when someone complains of dyspnea, you need to clarify what activity is it associated with. So, for example, are they having awareness of breathing after walking one flight of stairs? Or is it 2 flights of stairs? Okay. There's also a related condition called orthopnea. So here, patients describe a feeling of drowning when they are lying down. And it's because of a cardiac condition, specifically a left-sided heart disease. Why does it happen? It's because of fluid overload. When patients recline or when patients lie down, then the fluid goes into their lungs, causing congestion. Okay, so orthopnea. So when someone complains of orthopnea, what do you need to clarify? Do they need additional pillows in order to breathe properly? If they need 3 pillows, that's a condition called 3-pillow orthopnea. Okay? In contrast, if dyspnea is shortness of breath, or which is an uncomfortable awareness, so there's some subjectivity there, right? But wheezing is objective because it could be audible not just to the patient but also to an external observer. These are musical respiratory sounds. So you commonly see this among patients with asthma. No? Okay. As well as foreign body obstruction. So you see this phenomenon or this complaint, this symptom among patients with partial lower airway obstruction, meaning the obstruction is at the level of the bronchi, not at the level of the pharynx. Okay. Lastly, we have cough. A cough is a reflex response to stimuli irritating receptors in the larynx, trachea, or bronchi. So the stimuli could be many things. It could be an infectious agent. It could be inflammation or blood or even foreign body. Okay. So when someone complains of cough, what you need to ask is duration. So you classify it into acute, subacute, or chronic. Acute causes are usually viral or upper respiratory tract infections, especially if they do not have any abnormal lung sounds. Okay, so acute cough lasts for less than 3 weeks. There's also subacute cough that happens when someone has a post-infectious cough, meaning they have already healed or they have already recovered from the infection, but because of the remaining inflammation, their airways are still irritated. Therefore, they have lingering cough. Okay. Of course, you need also to rule out if someone has a bacterial conversion of the viral cough. Okay, and lastly, we have chronic cough, which lasts more than 8 weeks. So the differentials there are allergic rhinitis, also known as upper airway cough syndrome. This happens when you have postnasal drip, meaning because of your nasal secretions are dripping backward posteriorly, that irritates your airway, causing you to cough. Okay. Aside from that, it could also be asthma. The cause of the cough could also be gastrointestinal in origin, such as GERD or gastroesophageal reflux disease. Okay. And lastly, it could also be a side effect of a medication. So for example, angiotensin converting enzyme inhibitors or ACE inhibitors are known to cause cough or chronic cough because of the production of bradykinin. Okay. What are some examples of ACE inhibitors? This includes the drugs that end in pril, for example, captopril. Okay, and of course, because we're here in the Philippines, we need to consider a very common cause of chronic cough in the Philippines is tuberculosis. So if a patient has 2 weeks of non-resolving cough, especially if associated with symptoms such as night sweats, okay, yeah, as well as weight loss, unintended weight loss, then you have to consider tuberculosis. Next set of symptoms, we have sputum and hemoptysis. Sputum in Filipino, plema. Hemoptysis, dugo. Umubo ng dugo. So first, for sputum, you need to characterize the sputum. So if the cough produces sputum, then the cough is said to be productive. Okay? So you have to assess the sputum's volume, color, odor, and consistency because it gives you a clue as to the etiology of the disease. Although this is not very reliable, if I'm going to be honest with you. Okay? So viral infection. Viral infections generally produce less flagrant inflammation than bacterial causes. So viral infection causes a mucoid, which is a translucent in appearance as well as whitish and gray in color, while bacterial pneumonia causes a purulent sputum, which is yellow or greenish in color. And lastly, we have anaerobic lung abscesses that could produce foul-smelling sputum. Okay, those are caused by anaerobic bacteria. Okay, so for hemoptysis, when a patient coughs up blood, we need to clarify, is it actually coming from the lower respiratory tract, in which case it is actually hemoptysis, or is it coming from the gastrointestinal tract, or from the nasopharynx? So what are some examples of this? For example, patients with peptic ulcer disease are said to have upper gastrointestinal bleeding. So sometimes you could get confused because it appears that they are coughing up blood, but that actually comes from their stomach. The management, of course, is going to be very, very different. It could also come from the nasopharynx. So for example, in the case of nosebleeds or epistaxis caused by an injury, most likely from nose picking to the Kiesel back plexus. So sometimes the bleeding, instead of going outward or anteriorly, it could go posteriorly, and it could confuse you as hemoptysis, but it's not actually hemoptysis. It's still just a nosebleed. Okay, so there are many causes of hemoptysis. It could be bronchitis, malignancy, cystic fibrosis, and less commonly, even cardiac diseases such as mitral stenosis, as well as bronchiectasis. Okay, so in the Philippines, what are you going to consider? Probably tuberculosis. Before we discuss the actual conduct of the chest examination, let's tackle some health promotion topics. So we have 3 here. The first is tobacco cessation. Later, we're going to talk about lung cancer screening. And lastly, immunization. Okay. Tobacco use is the leading preventable cause of premature death in the United States. Quitting significantly reduces disease risk. Clinicians have an important opportunity to identify and treat tobacco dependence. So what's the approach? Here you have the 5 A's model, which stands for ask, advise, assess, assist, and arrange. Ask, do you have a plan? Do you have plans of quitting? It's okay if the patient do not have any plans of quitting yet. So they may still be in the pre-contemplation stage. Pre-contemplation means they are not planning to quit anytime soon. Contemplation means they are thinking of quitting, but they haven't done any concrete steps towards it. Preparation means they are doing concrete plans, and they are actually doing it in the action phase or the action stage. And lastly, maintenance. Okay, so after asking, you should advise the patient accordingly. So if the patient is not yet ready to quit, then you could educate them on the benefits of quitting. Here we have the benefits of quitting. Within 1 year, your risk of heart attack and congestive heart disease, or of risk of dying from congestive heart disease, is halved. Second, within 2 to 5 years, your stroke risk reduces to that of a non-smoker. And lastly, within 10 years, your lung cancer risk is going to be cut in half. So those are the advantages that we need to inform our patients. Okay? Okay. So ask, advise. Next is assess. Assess the patient's readiness. Are they ready to quit? Or do they have any hang-ups yet? Do they have a need for additional knowledge on a certain topic? Okay. And lastly, second to the last is assist. Assist the patient in making their plans, and lastly, arrange. So you could refer the patient to specific support groups, etc. Okay. So from smoking, let's now talk about lung cancer screening. So smoking causes lung cancer. Okay? Smoking accounts for 90% of deaths from lung cancer. And actually, lung cancer is the leading cause of cancer death. It's the deadliest cancer. Okay? So with screening, you aim to target and diagnose early stage cancers. So because cancer when caught early, specifically lung cancer when caught early, could improve survival rates. So the specific recommendation I'm going to teach you is from the USP STF. So these are US recommendations. Of course, there are different Philippine recommendations, and of course, it's going to depend on the institution in which you're going to practice later on. But the USP STF recommendation is annual CT scan for adults age 55 to 79 years old. Elderly, right? Because that's the onset, that's the most common age of diagnosis of cancer. With a 30-pack year smoking history, who currently smoke or have quit within the past 15 years. It's because the risk of lung cancer from smoking disappears very gradually. So even after 15 years, even if you have already quit around 15 years, you still need to be scanned for lung cancer or screened for lung cancer. And lastly, for the health promotion topics, let's talk about immunizations. So there are two which are most important, the flu vaccine and the pneumococcal vaccine. Okay, so the influenza vaccine protects against the influenza virus, not Haemophilus influenzae. Okay, just to clarify. So the Centers for Disease Control Advisory Committee for Immunization Practices advises that annual vaccination should be given for everyone aged 6 months or older. So it's for everyone, including you and me. Especially high-risk groups, for example, adults 50 years old or older, pregnant women, and adults with chronic conditions. And add to that, healthcare personnel. So, medical students like you should be getting the flu vaccine annually. Okay, aside from that, we have the pneumococcal vaccine, which protects against Streptococcus pneumoniae. So there are two types of vaccine, pneumococcal conjugate vaccine and the polysaccharide vaccine, PPSV23 and PCV13. So the numbers correspond to the valency, meaning the number of subtypes that they target. So PCV13 targets 13 different subtypes, which is 13 valent, while PPSV23 targets 23. Okay? So it's recommended for all elderly patients. So yung mga nag-mandatory retirement na sa gobyerno, meaning 65 years old and older. It's also recommended for younger patients with certain predisposing conditions, such as immunocompromise, as well as chronic illnesses, for example, heart or lung disease, diabetes, etc. Also those who are smokers and those with asthma. Now let's proceed to the last and most important part of our lecture, which is the techniques of examination, starting with the initial survey. So what's the proper positioning in examining a patient for their chest examination? So for best results, you examine the posterior chest while the patient is sitting down, and the arms should be folded on the patient's chest in order to swing the scapula away from the back. Okay. After that, you ask the patient to lie down. So with the patient supine, you examine the anterior thorax. So what if the patient is unable to sit? For example, post-MI. Well, for that, you could just ask the patient to roll to their side to examine the posterior thorax. Okay? So what are you going to observe? You're going to observe the rate, rhythm, depth, and effort of breathing. Okay? What's the normal rate? Respiratory rate? Around 12 to 20 breaths per minute. But of course, it's different if in the pediatric population, especially in neonates. So this is for the adult population, of course. If it's too slow, then it's called bradypnea. If it's too fast, it's tachypnea. Tachypnea is around 25 breaths per minute. Okay? You also need to check the rhythm. We're going to discuss later on the different types of rhythm. So there are special patterns like chain stokes, apneustic breathing, so many types. Okay? You also need to look at the patient's color. So look for cyanosis at the patient's lips or tongue. If you look at the membranes, there should be no central cyanosis. Okay, you could also check the patient's palms if there is any pallor and if there is any sweating or diaphoresis. Why are you looking for these signs? Is because this may be seen among patients with either pneumonia or cardiac disease. Okay. You could also listen for audible sounds, even without your stethoscope, of course. One of the most worrying things you could listen to is the stridor, which is an inspiratory whistle. Stridor is an ominous sign of upper airway obstruction. In other words, you need to intervene. You need to intubate the patient. Okay. Lastly, you could check for accessory muscle use. As I have mentioned earlier, we use the diaphragm mostly for inspiration. But if you use the neck muscles like the sternocleidomastoids or the scalenes, or if you could see any retraction of intercostal space, then that means there is increased work of breathing. The patient has labored breathing. Okay. So the physical examination follows this pattern: inspection, palpation, percussion, and auscultation. That's the same trend or pattern you follow in most of the physical examinations, except for the abdominal exam. Because in the abdominal exam, you auscultate first before doing palpation and percussion. Okay? So, starting with inspection, what are you going to look for? So, when you inspect, you look at the shape of the chest. Specifically, you look at the ratio of the anterior-posterior diameter to the lateral diameter. So, the normal diameter is around 0.75 or 0.7 up to 0.9 in the elderly population. In other words, your thorax should be wider than it's deeper. Okay, why are you looking for that? Because in some conditions such as chronic obstructive pulmonary disease, they have a finding called barrel chest, in which their ratio of the anterior posterior diameter to the lateral diameter becomes greater than 0.9. Okay? In other words, the shape of their thorax becomes more circular. Okay, so aside from that, you could also note how the chest moves. Is it symmetrical or not? So sometimes if there's a very large pleural effusion, it could become asymmetrical. You need to look for deformities. So it could be anatomical, like pectus carinatum or pectus excavatum. So these are rib cage anomalies. Okay? There could also be abnormal muscle retraction. So you normally see abnormal muscle retraction in obstructive lung diseases such as asthma as well as COPD. And you're going to look for it at the lower intercostal spaces. Okay? So there. That's for the inspection part. Okay? First part done. Now let's move on to palpation. So for this, of course, you use your hands. So for the chest, you palpate for any tender areas. So you ask the patient, may masakit po ba? Is it painful when I touch this? Or is it painful when I release my hand? So there's a difference between pain and tenderness. Okay? Pain is direct pain. When you apply direct pressure, it's painful. It's tenderness if when you raise your hand, it becomes more painful. Okay? And also there may be in the chest palpable crepitus. Crepitus is a crackling sound that may happen when you palpate and there is air in the subcutaneous tissue. Okay? Air in the subcutaneous tissue. What's the cause? There are many probable causes, of course. Aside from that, you could also palpate for step-offs. So some people with rib fractures could have palpable a break in the bone. Okay. Next part of palpation, you place the thumbs at the 10th rib. So, for example, I'm applying my hands here on the posterior of the patient. Then, you watch for chest expansion. Okay? You look at your thumbs. Are your thumbs moving away symmetrically or not? Okay. So that's how you test for symmetric movement of chest expansion. Okay? Third, you need to check for tactile fremitus or vibrations. So how do you do that? You use the balls of the fingers, of the hands, or the ulnar surface of your hands. Then you apply it on the patient's back. Okay? So what are you feeling for? You're feeling for the transmission of the sound from the larynx to the surface of the thorax. So normally, it's going to be transmitted well. But if there's any obstruction, if there's a mass, if there's a pleural effusion, or whatever, whether solid or fluid, then the tactile fremitus is going to be decreased. Okay? So, how do you do it? So again, use your balls or your ulnar surface of your hands. Then you ask the patient to say 99. But in the Philippines, we have a different way. We ask the patient to say tres tres. Okay? Tres tres. They say it, they need to say it out loud for tactile fremitus. Okay. So asymmetric decreased fremitus could suggest pleural effusion or pneumothorax. Asymmetric increased fremitus could suggest unilateral pneumonia or consolidation. So if it's air or fluid, then fremitus is going to be decreased. But if it's solid or something like a dense fluid, it's going to be increased. Okay? So as long you're checking for symmetry. So after inspection and palpation, we move on now to percussion. So percussion, in Filipino, nagtutok-tok ka. So what are you going to use? You're going to use your pleximeter finger, which is your left middle finger. So you apply the distal interphalangeal joint on the surface you want to percuss. So in the thorax, of course, it's in the interspaces. Okay? And then using a swift motion of your hand, of your wrist, rather, you're going to tap the flexor finger on the pleximeter finger. Okay? And you use the tip of the flexor finger, not the pad. Okay? Not this pad, the tip. Okay? Okay, so you tap like that. Why is it important to do that? It's because it's going to tell you whether the underlying structure is air, fluid, or consolidated. And the pattern, when you do it on the patient's back, is a ladder pattern. Meaning, you move from side to side, like this. Why? Because you're comparing symmetry, of course. Okay, so what are the possible sounds that you could hear? Okay, so if it's fluid, it's going to be flat, which is soft, high pitch, and short. So you could see that if there's fluid in the pleural space. For example, a large pleural effusion. Okay, dull if it's solid. So normally you could observe that in the liver, over the liver. So try it on your liver right now. But aside from that, if there's consolidation of one of the lobes of your lungs because of an infection, a condition called lobar pneumonia, is also going to be dull. Okay? So the healthy lung is air-filled, right? So it's going to be resonant. Meaning it's going to be loud, low-pitched, and long. Okay? But there are some conditions in which the lungs are hyperinflated. For example, in chronic obstructive pulmonary disease or COPD. So there, the percussion sound is going to be hyperresonant. It's going to be very loud and lower pitched. And lastly, if you try it over your stomach, here, on your right upper quadrant of your abdomen, it's going to be tympanitic, loud and high pitched. So those are the different sounds that you could hear with percussion. Of course, you want to know whether the lungs are normal, meaning the percussion note is resonant, or if it's fluid filled, or if there is any consolidation, for example, pneumonia or even masses or tumors. Okay? Okay, so after inspection palpation, percussion. We move on now to the most important part, probably, which is auscultation. Okay, it's the most important technique for assessing airflow. So for this, you use the diaphragm of the stethoscope, which is the larger part, which is not the bell. Okay, we use the diaphragm. Okay, so you ask the patient to breathe deeply through an open mouth, not through their nose. And also, if the patient is congested, you ask them to clear their throat first. Because sometimes also, if you have a clogged nose, it could also interfere with your auscultation. Also, when you perform auscultation, ideally, you should always place the diaphragm against the skin, not against cloth. No, hindi sa damit ng pasyente. Because that could cause, sometimes, abnormal sounds. Okay? That could confuse you, especially if you're still a beginner. So, we also do the ladder pattern, which is what we did in tactile fermitus, right? Because we're comparing symmetry. So there are two types of sounds: normal breath sounds and adventitious or added sounds. Okay, normal breath sounds, of course, are normal. And we could differentiate between four types: vesicular, bronchovesicular, bronchial, as well as tracheal. Okay. So, but all of them are normal. It's just that they sound differently depending on which area you're listening. So, of course, you need to be familiar with the normal first before you learn about the adventitious or the added or abnormal sounds. Okay. So, vesicular, I want you to think of it as the sound of air coming in and out of the alveoli. Okay. So, when you listen to it, it's soft, low-pitched, and it's heard over most of the lungs. So it's the most typical lung sound that you're going to hear. So here, it is soft and low-pitched, and the inspiratory part is longer than the expiratory part. Okay? In contrast, bronchovesicular breath sounds could be heard over the first and second intercostal spaces anteriorly, as well as between the scapulae posteriorly. Okay? It's intermediate in pitch, so it's slightly higher than vesicular sounds, but here the inspiratory part and the expiratory part are almost equal. Okay? Next, we have bronchial sounds, and it's heard over the manubrium of the sternum. It's bronchial, obviously, because it represents air passing through the bronchi. So in terms of sound and pitch, it's higher pitched and it's louder. Also, you may hear a break in between the inspiratory and the expiratory part. Also, the expiratory part may be longer. Lastly, we have tracheal sounds, which are loud, harsh sounds heard if you place your stethoscope here at the neck, at the trachea. Okay? So it's loudest out of all of these four. Okay? Okay, so now that you know what's normal, you should also learn to identify what's abnormal or adventitious or added. So there are many different types. Okay? But the two most important ones are crackles or rulls, which are discontinuous popping sounds. So think of it as dots, dotted. So you could see it among cardiac conditions as well as pulmonary conditions like heart failure and pneumonia. In contrast, you could hear whizzes, which are more musical. So think of them as dashes. Okay? Dashes which are seen in obstructive lung diseases such as asthma and chronic obstructive pulmonary disease. Okay, so let's differentiate further between crackles and whizzes. Crackles could be divided further into fine or coarse. Fine just means it's higher pitched, but coarse means it's lower in pitch. Okay? Okay. So, there are also bronchi. So, the usage varies depending on the clinicians, but many clinicians refer to it as sound that varies depending on the secretions in the airway. Okay? So, it's snoring in quality and low-pitched. Lastly, we have pleural rub. Pleural rub can be heard if there is a grating sound from inflamed pleura. For example, pruritus. Okay, so those are the adventitious or added sounds. The most important ones you need to recognize are the crackles or rals and wheezes. Okay? Okay. So if you hear any adventitious breath sounds, you need to assess for transmitted voice sounds. So normally, sound is transmitted poorly from the larynx to the surface. However, it could be increased if there is consolidation. For example, lobar pneumonia, because there is fluid in the lungs. Aside from pneumonia, transmitted voice sounds could also be seen in pleural effusion, meaning the fluid is not exactly inside the lungs, but in the pleural space, the potential space around the lungs. Okay, so there are 3 transmitted voice sounds that I'm going to teach you: gophony, bronchophony, and whispered pectoriloquy. Again, you do it if there is any adventitious breath sounds. So for example, in your chart, if there are crackles or ralls, as well as wheezes, your consultant is going to look for these transmitted voice sounds. Okay, so first with egophony. For all of this, you use your diaphragm, the diaphragm of your stethoscope. Take note, it's different from the percussion of tactile fremitus. Okay, so for egophony, you ask the patient to say, "He." Now, listen to the sound that's coming from the diaphragm of your stethoscope, not from the patient's mouth. Okay? If there is a change in sound from E to A, then that's called egophony. So you just write in your chart, egophony. Okay? Next. In English, you ask the patient to say 99, but in the Philippines, you ask the patient to say tres tres. Normally, it's going to sound muffled. But if it comes out loud and clear, then you're going to write in the chart positive for bronchophony. And lastly, you ask the patient to whisper 99 or tres tres. No? This time you need to whisper it. So normally, you're probably not going to hear it because the patient is whispering, right? But if it's heard loud and clear, then positive for whispered pectoriloquy. Now all of these are just transmitted voice sounds that could be suggestive of consolidation of lobar pneumonia or fluid in pleural effusion. Okay? So that's it. But before we end, let's quickly summarize what we've learned today. So let's try to apply it in different conditions. Okay? So starting first with the normal findings. So with normal findings, percussion is going to be resonant over the lungs because of air. So most of the lungs is going to have vesicular breath sounds. So normally you don't have any adventitious breath sounds. And of course, tactile fremitus is going to be normal, symmetrical, not increased, not decreased. Okay, so what happens if you have an infection? If you have a lobar pneumonia, if you have an infection causing such an immune response that there's going to be fluid or pus or exudate in your lungs, yeah. So because it's going to be fluid, the percussion is going to be dull because it's consolidated. The breath sounds is going to be bronchial over that area, meaning the alveoli have collapsed or have been filled with something else. So you're going to hear not the air coming from the alveoli, but the air coming from the bronchi. Okay? The adventitious sound you're going to hear there are what we call late inspiratory crackles. Late inspiratory crackles. And the tactile fremitus is going to be increased because there is increased transmission of the sound from the larynx. Okay, next, if you have chronic bronchitis, the sound is going to be resonant because there's no consolidation unlike lobar pneumonia. Okay, the breath sounds are still going to be vesicular, but you're going to hear adventitious sounds such as coarse crackles or wheezes. Okay, so what if you have a condition in which there is fluid in the pleura, in this potential space surrounding your lungs? Upon percussion, it's going to sound either dull or flat. The breath sounds could not be heard because the chest wall is apparently thickened because of the fluid. Okay? The tactile firmitude is also going to be decreased. What if instead of fluid, of pleural effusion, you have air? For example, the condition called pneumothorax. So upon percussion, the sound is going to be hyperresonant because it's air. Okay, the breath sounds are also going to be decreased because the thickness of the chest wall is effectively increased, right? Okay, and the tactile firmitude is also going to be decreased. Okay, lastly, let's look at this obstructive lung diseases. So with obstructive lung diseases, there's problem with inspiration or inhalation. Okay, so there are two types here. Chronic obstructive pulmonary disease. You should usually see this among chronic male smokers. Okay, so the appearance of their chest or their thorax is barrel, so widened or wider anteroposteriorly. Okay, so if you percuss it, because it's hyperinflated, because of the ball valve effect, it's going to be diffusely hyperresonant. Okay, it's different from the normal lung. Okay, the breath sounds are also going to be decreased to absent. So the lungs are inflated, but the air is not moving in and out properly. Okay, sometimes you could hear wheezes. So with remember, obstructive lung diseases are associated with wheezes. Remember the musical sounds dash like in pattern. Okay, lastly we have asthma. Asthma is also going to be hyperresonant. The lungs are also hyperinflated, but a prominent finding would be wheezes. Okay, because of the difficulty breathing or because of the musical sound of the wheezes, normally the breath sounds are going to be obscured. Okay, alright, so that's just it for our chest physical examination. If you have any questions, just message me. Thank you very much, everyone.